Hello.
Exactly. Bihar State Government Education Department మీరు ఒకటి బోర్డ్ ప్రిపేర్ చేసి బీహార్ స్టేట్ అంతా పంపించింది అటెండ్ బీహార్ యూపీ వాళ్ళ సర్వ శిక్షా అభియాన్ కాలేజ్
ఖాళీ గణిత ఆశీర్వదం కాదు ఓకే. They will start, sir, or we have to start? They will start, or we will stop?
Yeah. If people have joined, you can start.
But where it is audio is not coming.
Huh?
Audio is not coming only mine.
Audio is not coming in the moment. हेलो सर शुभम सर वो
Audible.
लॉगिन हो गए लेकिन आपकी तरफ से लॉगिन नहीं हुआ सर सीआरई प्रोग्राम ऑनलाइन का आप नहीं दिख रहे ना हाँ वो भी म्यूट पे है वॉइस भी नहीं आ रहा स्टार्ट अब स्टार्ट कर सकते क्या हमारे साथ कैसा हाँ
Good morning, participants. Is it audible? Okay. Welcome to CRE program on multidisciplinary perspectives on cerebral palsy, integrating new development across specialties. That means we'll be seeing with the different specialties what is the newer developments in the field of physiotherapy, occupational therapy, and speech therapy. Okay. Let me start with the session today. The first session will be on physiotherapy aspects of the cerebral palsy, integrating with the new approaches. So before going to that into mainstream, we'll have a basics about with the cerebral palsy, what is cerebral palsy and why it is important, what is the role of physiotherapy, how the therapy can helpful, we'll be discussing in this session. Okay. When you see the definition of CP, it is a non-progressive neurological condition where there is group of permanent disabling symptoms resulting from damage to motor control areas of the brain that might originate before, during, or shortly after birth. That means you need to understand here there are two important points here. One is it is a non-progressive neurological condition. What is the meaning of non-progressive neurological condition means there will be a early onset of damage to the brain, but further damage will not occur. And whatever the signs and symptoms will be there, whatever the brain is damaged, that much only the signs and symptoms will be there. That means the neurological disease will not progress, which is a clear entity which can be differentiated from other conditions. Like when you take with other conditions where there is other neurological damage that can be a progressive. So this is one of the major condition where there is a non-progressive neurological condition, group of permanent disabling symptoms resulting from damage to the motor control areas of the brain that might originate before, during, or shortly after birth. That means the damage can occur before the birth or during the birth or shortly after the birth. So these three important points are very important because when you go with the assessment of the child with the CP, we need to take in the history aspect the same thing. That's why the definition is very important. Okay, before, during, shortly after. That's why we'll take a prenatal history, natal history, postnatal history to rule out the conditions it is where the damage has occurred before birth, during birth, or after birth. So that is the importance of this. Okay, a non-progressive neurological condition, a group of permanent disabling symptoms resulting from damage to the motor control areas of the brain that might originate before, during, shortly after birth. Okay, now if you see how common it is, there. So cerebral palsy is diagnosed in approximately 8,000 children each year. Okay, it is the most common cause of childhood physical disability. So when you see in the childhood disability, in all the physical disabilities, if you see, this is the most common cause for cerebral palsy. So you can see how impact it is there in the physical disability. So cerebral palsy need to be considered and it need to be a highest preference. Okay, and we need to consider in all the diagnosis because every time there will be overlapping of signs and symptoms with the childhood diseases, particularly with the developmental delays. Here also there will be developmental delays will be there, but particularly when you see that, so there will be more about physical disability will be there. So this is the most common cause of childhood physical disability. Okay, as I was telling you, so it will result in a symptoms. So what are the major symptoms of the brain damage? So when you see, I just mentioned in the pyramid wise. So when you see this delayed milestones, delayed motor development, affected posture and movement. So you see the order of the pyramid if you see from the apex to the base if you see. So in the base if you see the larger area, what is finally it is affecting is person's posture and movement. That means when you see the in cerebral palsy, there are two major symptoms that will be affected. One is the posture, another one is the movement. So this can be because of number of reasons certainly why the posture will be affected, why the movement will be affected. Okay. So when you see that delayed milestones, so this will be correlating with other conditions, right? So we need to rule out that. And a delayed motor development, when you see particularly along with the other milestones also, motor milestones will be delayed here. So delayed milestones and delayed motor development also it is one of the important factor. And finally, it may lead to the posture and movement problem. So as earlier I was discussing with the starting, what are the factors for this brain damage? So there are a number of reasons for the brain damage. It can be with the prenatal, it can be with the perinatal, and it can be with the postnatal factors. So what are the main important prenatal factors? What are the perinatal factors? And what are the postnatal factors? So that we'll see in detail. So if you see the prenatal causes of cerebral palsy, so it may be of a number of reasons, particularly when you see with the fetus development, that is because of genetic disorders. So anything genetic influence also one of the major reason in the development of cerebral palsy. Then related to the mother pregnancy, seizure disorders, any mental retardation, previous pregnancy complications, all these need to be considered or you need to take when you are taking the assessment. Then particularly if the mother has any problems like RH incompatibility, placental rupture, drug or alcohol exposure. This you see commonly when you see with the smoking, drug addiction, alcohol consumption. With the mother, when the mother is having all these types of habits, this may affect the baby. This is the chances of affecting that. This is one of the cause for that. So you should be very careful. So when you are taking the history, we need to take with the history from the mother also. Does any of these habits are there? Okay. And as usual, the infections. When you see with the infections plays a major role, the development of cerebral palsy, the toxoplasmosis, okay, like rubella, cytomegalovirus, herpes simplex, anything it can be. Okay, so these are the some of there are a number of other causes. These are the major causes with the prenatal. Perinatal causes. So when you see the perinatal causes, asphyxia. What is asphyxia? Umbilical cord prolapse, breech presentation, low birth weight, pregnancies with multiple births. So self-explanatory asphyxia is when you see lack of oxygen. So the brain cannot sustain without oxygen and without nutrition. Okay, within few seconds also. That means the brain requires continuous supply of oxygen and continuous supply of nutrition. So without that, the brain cells will undergo damage. In a simple terms, the brain cells will undergo death. Okay, so the asphyxia part plays a major role. For the asphyxia to develop, it can be developed by n number of factors. Okay, so why the less oxygen is there? What is the reason for the less oxygen? That we need to analyze that. So this is a major cause in the CP. Okay? And as I told you, umbilical cord prolapse, I'll show you the picture, then you can understand. So that also will lead to asphyxia, breech presentation, low birth weight, and pregnancies with multiple births. So all these are the major reasons for perinatal causes. Can you see here umbilical cord prolapse in the picture? See, the umbilical cord is prolapsing. So during that time, it can be get compressed, and that can lead to the lack of oxygen supply. That is lead to asphyxia. That is okay. This is one of the major one. Next, as I told you, the breech presentation. You know, normally which part of the body has to come out of from the mother's womb? It is with the head. Now, can you see in the different types of breech presentations here? So when this type of presentations are there, so the baby will suffer with the lack of oxygenation. And also there are, it is not mentioned here, that there are deliveries like with the forceps delivery, forcible with the traction application. In all those cases also, there is a chances of problem. Okay. So this is again with the infections, you can see encephalopathies. This also can lead to the early stages. It can also lead to the development of CP. Okay, so prenatal, perinatal, now coming with the postnatal causes. The previous picture which I showed you, hypoxic ischemic encephalopathy. After the baby has born, so there may be chance of infections. So that may lead to the encephalopathy. Okay. So then traumatic brain injury, any injury, the baby will be falling down, or some injury to the baby, traction injuries, or a number of injuries it can be there. That can also lead to the development of CP, brain damage. So, okay, that was about very few things with the etiology and manifestations that. So we need to see one of the important aspect when you are discussing with the CP, it is classification of the CP. So on what category the CP is classified? So basically there are three categories how the CP is classified. One is topographical presentation and physiological presentation and functional presentation. Topographical presentation, physiological presentation and functional presentation. We'll see each one. Okay. So first one is the topographical presentation. Okay. Can you see this picture? So there is the body area is represented here and it is shaded in the parts like with the brown color it is shaded, right? So when I mentioned topographical, there is part of the limb, part of the body, which part of the body is affected. Based upon that, it is classified, the CP. Like first one, if you see the monoplegia, that is where was a one like left hand here, it is shaded, it is. So that shaded it is not working. That is the meaning. That means one part of the body is affected, that is upper limb is affected, left upper limb is affected. So it is called as a mono means single. Plesia means paralysis. Monoplegia, right? Now, second picture, if you see, it is with the hemiplegia. Okay, can you see here? Hemiplegia means half of the body is affected. Right here, right part of the head and neck, right part of the upper limb, right part of the trunk, and right lower limb, it is affected. So right hemiplegia it is, right? Okay, next, half of the body is affected, that is called as hemi. Okay, next will come as a diplegia. Now you can see both the lower limbs are affected. But some cases, the part of upper limbs also can be affected, but it is minimal. So then when the lower part of the body is affected, it is called as a diplegia. Okay. Next, when I mentioned here the quadriplegia, you can see all the four limbs are affected here. So this is the differentiation when you see. So this clinically, when you see the CP child, we can analyze at which part of the body part is affected, whether it is a monoplegia, whether it is a hemiplegia, whether it is a diplegia, whether it is a quadriplegia. And most common forms of this CP is the diplegia. So generally we will see this diplegia is very, very common. So that was about topographical presentation. Now we'll see with the physiological presentation. Okay. Okay. Now if you see this physiological presentation here. So in this slide, I'm just mentioning in the areas of the brain, which part is affected, what will be the feature, like I mean to say which part of the brain is affected corresponding to which CP it will develop. Okay. And when I mentioned here in the slide, you can see here the area of involvement and categories: spastic CP, dyskinetic CP, athetoid CP. There are three categories we have seen. So first one, when you see the under three categories, the spastic CP, can you see the blue color is in the shaded area in the brain? So you can see how the brain part, which part of the brain is affected here. You can see here spastic. Okay, in the three areas it is. Can you see as the involvement is more, we can see the more representation in the body also. Okay, so with the spastic CP, we have three presentations: hemiplegia, diplegia, quadriplegia. So this already just now we discussed that. So that all three categories comes under the spastic CP. Okay, you can see the area of involvement of the brain here. Okay, this is functional, physiological. Which part of the brain is affected? Next, when you go with the dyskinetic, okay, so that is there's a movement disorder will be there here. Okay, athetoid and dystonic it is. Tone abnormality will be there here. Okay. Next, ataxic, athetoid CP. So in ataxic or athetoid CP, we can see the breathing movements we can see. So we have involuntary movements will be seen. This is a particular feature of the ataxic. Okay, coordination will be affected. So each one will have the clinical features entity that will be differ from each one. Okay, so basically grossly we need to remember whether it is a spastic CP, whether it is a dyskinetic movement disorder, then whether it is a ataxic, that's coordination is affected. So in all these things, and when you divide into broad classification, in the down of the slide you can see pyramidal lesions and extrapyramidal lesions. The spastic will be lead to the because of pyramidal lesions, and extrapyramidal lesions leads to the dyskinetic and athetoid lesions. So this is the functional classification or physiological classification of CP. The same thing which I mentioned, here. Can you see here the spastic CP? Yeah, somebody was asking the what is the difference between pyramidal and extrapyramidal. It's a part. Pyramidal is corticospinal tract will be affected along with extrapyramidal tracts will be affected. That is the only difference, functional, physiological difference that is. And depending upon that, we will see the signs and symptoms. Okay, spastic CP, athetoid CP, ataxic CP. So spastic CP, as I mentioned, with the corticospinal tracts will be affected. So damage to the motor areas of cerebrum. So these are the areas of the cerebrum. You can see here. These are the areas of the cerebrum. Okay, that will be there. So we can see the signs and symptom is spasticity. I'll explain you what is the spasticity, and we'll see the synergy patterns. So synergy patterns is particular category of movements of all the joints. So they will go in one movement pattern. Okay, we have flexor synergy and we have extensor synergy. So when I mentioned a synergy pattern, flexor synergy, all the limbs will be bent position. When I mentioned extensor synergy, all the limbs will be in extended position. In a simple understanding for you. And spasticity is the increased in the tone, muscle tone. So when I mentioned a pathological increase in the muscle tone, that is called as spasticity. So these are the clinical features of spasticity. Okay. When you come with athetoid, damage to the basal ganglia. So these are the areas of the basal ganglia where we will see with the areas of the brain where the Sure, I'll share the PowerPoint. Okay, no issue. So when you see this, basal ganglia will be affected here in this category in athetoid. So where we'll see rigidity. So what is the difference between spasticity and rigidity? Spasticity will affect only one group of muscles, but whereas rigidity, it will affect with the both group of muscles, that is both flexor group and extensor group will be affected. So it will be very rigid. The movement is very difficult here in a simple sentences if I say. And it is monitored by involuntary movements. Okay, involuntary movements will be present. Okay, see the difference in all the cases. Next, third category is ataxic. I was explaining with the ataxic. Okay, then we can see damage to the cerebellum. So can you see here damage to the cerebellum in the third category? So okay, so this area will be affected. So then we will see hypotonia. In these two cases, we are seeing the hypertonia, that is increased tone will be seen. But in third category, we'll see hypotonia, and particularly it is manifested by incoordination movement, okay, like loss of balance and coordination. So this is a particular difference of three categories: spastic, athetoid, and ataxic. Okay, this. Okay, there is some issue. I'll show you the videos later at the end of the PPT. Okay, so when you see the associated conditions, so these are the major symptom-wise difference between all the three categories of CP. Along with these symptoms, we can see associated signs and symptoms also in the CP. That is, first one is the mental impairment. That is, the intellectual disability, learning disabilities, seizures, visual impairment, malnutrition, hydrocephalus, that is increase in the CSF fluid, pressure will be increased, then hearing loss. So there can be associated signs and symptoms also can be there in the CP. So that also you need to rule out when you are doing assessment. Okay, so this was about a brief introduction to the CP clinical aspect. So what we have to do with the physiotherapy wise. So before going with the physiotherapy treatment, I need to assess completely. So generally, how you do with this, like a special education, how will you do psychology, how will you do assessment when the patient, when the client comes. Similarly, when the client comes to physiotherapy department with the person with the CP, we need to assess. So what is the assessment aspect we are going to see? Again, it will take 5 to 10 minutes. Okay, so this will be again very important. Okay, so what assessment you will see? See, whatever I'm explaining, that will be correlated with the previous points or previous slides. So you can correlate that. So when you see with the PT assessment, it starts with the history. So any assessment will start with the history taking. So what will be the history here? So I'll ask the chief complaints of the patient. What is the chief complaints? So what will be the chief complaints? I'll ask whether the patient can able to answer. Otherwise, if I'll ask the parents, what will the problems? Obviously, there is two main problems that will be addressed by the parents. So that is one with the posture, one is the movement. So what will be delayed milestones will be there? Or the patient is not able to move, patient is not able to sit, patient is not able to stand. There are deformities are developed depending upon the severity and the what stage the parents are coming, what the stage the child is coming, what the stage, what age it is coming. Okay, so a number of factors will affect the chief complaints it is. So particularly whatever it may be, there is at the end product will be posture and movement will be affected. So that will be there. So posture and movement analysis can be done anyway. So all the movements, whatever you do, functional activities, sitting, standing, rolling, turning, whatever it may be, head control, everything comes under with the movement wise only it is. Okay. So in terms of posture, in terms of mobility, in terms of strength, in terms of balance, in terms of coordination, you see that 3 categories of CP. So different CPs will have different complaints it is. Okay. So that is comes under chief complaints it is. So then present history. So you need to take the history. I was telling you the prenatal history, perinatal history, postnatal history. So what are the factors that is affected that lead to the development of CP? We need to identify that. Okay. So that comes under with the present history. Then past medical history. So any drug related histories, any medications, any pharmacological history that you need to take. Okay. Then pregnancy and birth history, prenatal, perinatal, postnatal. That is I already explained you that we need to take very important. That is okay. And developmental history. So that I'll show you what is the developmental history in all the milestones that in the next pictures I'll show you. The family history and social history. So this is a complete history part. In any assessment, this will be there in the medical assessment, it will be there. Okay. Then we need to assess with the higher mental functions. So this will come on with the higher mental functions, importance of cognitive function, memory function, attention, okay, orientation function, okay, what is the level of, so all these things comes under with the mental functions that we need to assess. Then coming with the sensory examination. So what are the different kinds of sensory examinations you have to do? I'll explain you. Okay, reflex examination. So what type of reflexes we need to do? Primitive reflexes, deep tendon reflexes, superficial reflexes, that and all need to be analyzed. Involuntary movements. I told you why it is important. This is a particular feature of particular type of CP that's why we need to assess with the involuntary movements. Then we need to assess with the muscle tone. I was telling you about the muscle tone. It is whether it is spastic, whether it is a rigidity, or whether it is hypotonic, it is there. So this comes under with the part of muscle tone. Then muscle strength. So how much is the strength of the muscles it is there? Because the CP is a disorder of movement and posture. So obviously when the muscles are getting weak, so we need to assess with the strength. Then directly it is related with the muscle bulk. So we need to assess with the muscle bulk. And mobility, range of motion, range of motion, that is mobility of all the joints that should be assessed. So that we'll see in detail. And posture and postural reactions, balance, coordination. See, these are all important that will specify the which category of CP is affected. Functional mobility skills. Okay, so like patient can attain head control, patient can attain sitting, standing, walking, all those things we need to assess. Activities of daily living, what difficulties they have in the daily living activities, ADLs, ambulation it is called as brushing, eating, bathing, etc. A number of activities we can include. Recreation, leisure activities, adaptive equipments, what adaptive equipments they are using. Yeah, somebody has raised the hand. Nihar. What is the doubt? Somebody has raised the hand. Okay. So recreation, leisure activities, adaptive equipments. So planes, wheelchairs, what presently the child is using. So that and all we need to take into consideration. Okay. This was the grass motor developmental milestones. Okay, when you see the key gross motor developmental milestones, when you are taking the assessment, that we need to see. So when you see the age wise, 3 months, 5 months, 6 months, 8 months, like that. So first one, we see the first basic milestones, the neck holding. So we need to see the neck holding. Okay, whether the baby has attained the neck holding or not. This is the primary thing. Next one, go with the 5 months, rolling over, 6 months, sits with own support, 8 months, sitting without support, 9 months, standing with support, 12 months, okay, creeping, okay, standing without support, 15 months, walks alone, creeps upstairs, 18 months, running, okay, 2 years, walks up down the stairs, 3 years, bicycle riding, 4 years, hopping. So all these are the major gross motor developmental milestones that we need to assess, particularly very, very important in case of in the CP. It is neck holding, rolling, sitting with support and without support, standing with support and without support, creeping, walking, running. So all these are the fundamental motor milestones that we need to assess. So that's whatever I mentioning is in the pictorial representation. We can see is the child is neck holding, rolling, sitting, standing with support, independent standing, and walking. So the same, there will be overlapping of ages can be there, but that will be the major one. So again, the same picture you can see, like suppose one example, how can you assess with the delayed head control is there. So this is the position, the baby is in this position. Then you just hold the both the hands of the baby. Then you just pull it upwards. You just pull the baby upwards, okay, towards your side. Then if the head lagging is there, okay, can you see this? If he has a head control, automatically the head will be lifted from here. So otherwise it will not be problem. It will be head will be dropped down. So these are the milestones, gross motor milestones, that is. Okay, this you can see in the again with the pictorial representation. 0 months, 1 to 2 months, 0 to 3 months, you can see complete head raising, it is there. Okay, now you can see in the 4 months and 5 months, you can see the baby is able to turn. Then you can see 6 months able to sit, reaching activities, then able to stand, then crawling, you can see standing with support, then you can see independent walking. Okay. Like motor milestones, we need to assess with the social and adaptive milestones. So like suppose if you see with the 2 months of age social smile, so 3 months you can recognize the mother. So strangers by 6 months, recognition of strangers by 6 months, says bye-bye and social interaction by 9 months. Okay, then 12 months you can say play with the simple ball games, and speech you can see by 15 months, jargon speech. 18 months you can see parents imitation they can do. 2 years you can see ask for food, drink, toilet, all these activities will come by 2 years. Then you can see 3 years sharing of toys. 4 years you can see cooperation in the group. Okay, again helping with the other activities 5 years. So these are the social and adaptive milestones. So this already explained you with the higher mental function. Both cognitive and neurophysiological functions has to be assessed, memory, attention, all those things. Sensory examination. So in the sensory examination, we have different categories of sensation that has to be assessed. Superficial, deep, and cortical sensation has to be assessed. Like particularly when you see these cortical sensations, so like as I mentioned in the slide, it is tactile localization, stereognosis, tactile discrimination. Okay, so when I mentioned a tactile localization, that means if you take any sensory object that is with a brush or anything, if you touch it on whichever the body part you are touching, the child or the client has to identify that where is the location of that touch. That is called as a tactile localization. Then stereognosis, it is a sensory sensation where we can able to identify the familiar objects. Like suppose we will ask the patient to close the eyes, and what are the familiar objects like pen, pencil, or mobile phones, or anything which is familiar to him. And if we keep that one in the hand, and we'll ask the patient to identify that, because we can identify the familiar objects. That is called as stereognosis. Because in case of this brain damage, all these senses can be affected. Then tactile discrimination, whether when we are able to touch with two sharp objects, we need to take two sharp objects, and then we need to identify when you are touching with one sharp object or two sharp objects, they should be able to differentiate. That is called as a tactile discrimination. Okay, so this is particularly with the somatosensory cortex. When somatosensory cortex is affected, so we can see this type of signs and symptoms. And this is the next important parameter, that is the muscle tone. So as I mentioned, the muscle tone is an important parameter. So usually it will be checked with the repeated passive movements. So when you check a repeated passive movements, when the therapist is feeling any resistance to the movement, okay, so normal resistance will be there. If you are feeling with the more resistance, so the normal resistance will become a tone, muscle tone will be there. If you are feeling the resistance in one direction more than the other direction, so then we need to grade it as an hypertonicity. So when we are seeing in the one group of muscles, that is called as spastic muscles or hypertonic muscles. And when you are seeing in the same hypotonicity in both group of muscles, both, that is flexors and extensor group of muscles, it is called as a rigidity. And if at all we don't see any tone only, we cannot feel any resistance in the movement, then we can name it as a hypotonic. Because three categories of CP, we will see three types of presentations, that is. That is about with the muscle tone. Reflexes. So again, this is one of the important thing, primitive reflexes. So very important, that has to be assessed in the early stages. So that will give an identification whether the development is there or not, whether the reflexes are integrated or not, that will give you a clue. So there are so many primitive reflexes are there. I just mentioned only three here. I'll just show you what is the response, how to illustrate that. You see the name asymmetric tonic neck reflex, symmetric tonic neck reflex, tonic labyrinthine reflex. Okay. Then deep tendon reflex, this is common in adults also will check. Then Babinski sign and clonus. So I'll explain you these primitive reflexes. Okay. Can you see the first one? Tonic labyrinthine reflex. When you see in the picture, as shown in the picture, if you see, just hold the baby as shown in the picture. Then you just bend the head downwards. That's the second picture here. If you bend the head downwards, you can see the limb positions. All the limbs will be flexed. All the limbs will be bent position. It comes to bending position. And suppose if you extend the head, okay, if you lift the head, automatically your limbs, that is both the upper limbs and lower limbs, will go into extension. So this is called as a tonic labyrinthine reflex, prone reflex it is. Now you can see the tonic labyrinthine supine position also you can do. Can you see when you bend the baby at the neck, automatically your upper limbs and lower limbs will be bent. And when you bend the baby head backwards, that is in extension position, supine line, you can see extension of the limb positions. So this is tonic labyrinthine reflex you can do in supine and prone position. Just play at the level. Play at the level. I just show the videos at the end of the session. Okay. Next one is STNR, that is symmetrical tonic neck reflex. Okay. So here the stimulus will be head itself, head position itself will give a stimulus, then automatically reflex will be illustrated. So when you bend the head position here, like suppose the stimulus of the head is, yes, these are the normal reflexes within the time period. It has to be integrated. Like suppose, can you see here, I mentioned here, symmetrical tonic neck reflex, STNR, normal age of response is 6 to 8 months. If it is persisting after 8 months, it will become abnormal. It should not be persistent because it will interfere with the function. So that's what I'm going to explain here. Okay, so the stimulus is head position, whether if you keep with the head in flexion or if you keep in head in extension. If you keep the head in flexion, both the arms will be flexed and both the legs will be extended. Or vice versa, when the head is extension, arms will be extended, legs will be flexed. Vice versa it is. So the normal age of response is 6 to 8 months it is. It interferes with, suppose if it is presenting after 8 months, so these all problems will be there because the baby cannot crawl. You can see, okay, maintaining hands on his position is very difficult. A sitting balance will be affected. Number of things will be there. So it has to be integrated according to the development it is. So initially it is normal within the time period. After the time period, it should not be persisted. It's also not working actually. I'll show you these videos at the end. Okay, next one is asymmetrical tonic neck reflex. So before which I showed you was the symmetrical tonic neck reflex. Now this is asymmetrical tonic neck reflex. Asymmetrical tonic neck reflex. So now you can see in the picture here. Can you see in the picture here? Like again, here's the head position is the stimulus, and you see the position of the limbs here. Suppose if I turn the head position towards the right side, Okay, this is the right upper limb, this is the left upper limb. So whatever the side I'm turning the head towards the right side I'm turning here, then that side upper limb will be extended, that will become straight, and opposite limb will be bent, that is flexed. Okay, this is the response. That's why it is called as a asymmetrical tonic neck reflex. Before thing, this was symmetrical tonic neck reflex. That means when I bend the position downwards, both the upper limbs will be bent and both the lower limbs will be extended. That will be symmetrical response will be there. But here it is asymmetrical response will be there. Okay, so that's why it is called as a asymmetrical tonic neck reflex. This also I'll show you because some technical issues there that PPT is not placing. I'll show you directly videos. Okay, this what? Persistence of primitive reflexes and impairment of function. So suppose if tonic labyrinthine reflex is there, so rolling from supine to prone is very difficult it is. So that's why if it's not be persistent, it should be integrated within the time period. If it is persisting means there is some problem is there in the brain. That indicates, that's why I told you, this is assessment. During assessment, we'll be assessing the all the patterns, all the things, all the components. Okay, ATNR, STNR, these are okay. Now coming with the muscle strength. So there is one problem when assessing the strength because of spasticity or dystonia, that is altered tone. We cannot exactly assess the strength. But in case of with the hypotonia, we can assess with the strength. So we need to take into consideration spasticity when you are assessing the muscle strength. So muscle strength will be assessed using with the MMT. MMT is a manual muscle testing. Manual muscle testing is used by the therapist to check the strength of the muscles with his manual resistance. So then mobility. So we need to check with the mobility of all the joints, the body. So like mentioned here, the upper extremity, you can see scapulars, elbows, supination, all these things you need to assess. And particularly, if you remember in the previous slides, I mentioned as a that is a pattern, flexor synergy, extensor synergy. So when particular type of synergies are there, particular muscles will undergo with the tightness restriction. Range of motion will be restricted. Like you can see here, I mentioned in the upper extremity, that is upper limb. Upper extremity is upper limb. So scapular protraction is scapula will be forwarded. Elbow extension, elbow in extended position. Supination, wrist and finger extension. Okay, all these things will be affected depending upon the flexor synergy or extensor synergy. So now we can see in the lower extremity. So hip adductor tightness common, hip flexor tightness, knee flexion contractures, ankle dorsal, that is plantar flexor tightness. So whatever I mentioned in the bracket, that muscles will undergo tightness and opposite movement will be affected. Okay, so these are the movement restrictions in the upper limb and lower limb, and the common pattern of restriction. This is the common pattern of restriction. It is. So what deformities will be seen? What deformities will be seen? Now, if you see that after mobility is affected, we need to see number of deformities. That is elbow flexion, wrist flexion deformities, scoliosis, lordosis, femoral anteversion, tibial torsion, patella alta, forefoot varus, forefoot valgus, forefoot equinus. All these things are the different categories of abnormalities that will be. So postural control. So we see basically static posture and dynamic posture. You're not able to listen? Is not audible? Is it audible? Okay. So postural control is both we need to check with the static posture and dynamic posture. So involuntary movements. So as I told you, the involuntary movements, it can affect particularly with the extremities, but it can also sometimes can be seen in the head and neck also. So we need to assess with the involuntary movements. Coordination. We need to check with the coordination, particularly very important in case with the ataxic CP. Balance. So again, static balance and dynamic balance we need to assess. So it's broadly classified into two categories, static and dynamic. Both the categories we need to assess. Okay. So that in terms of head control, in terms of trunk control, everything comes under balance. Then we need to see how the CP child is walking. So by assessing the gait pattern, we can see what category of gait CP it belongs to. Like suppose when I said a spastic CP, when both upper limb and lower limbs are affected, in case of crouched gait will be there. Okay, like suppose when you say the diaplegic CP, very common CP in all those cases, and because of tight spasticity of adductor muscles, okay, we can see scissoring gait. So if you see the scissor, how the scissor will be there, both the lowers will be the pattern of scissor it will be. So when the child is walking, one limb will be crossed over the other limb because of the tightness of the muscle or spasticity of the muscle. So that type of presentation will be called as a scissoring gait. It is. Then we have a circumdactory gait when half of the body is affected, that is in case of hemiplegic CP. So in those cases, we will see circumdactory gait because of lack of abductor muscle strength. Okay. Ataxic CP, we can see like where, like suppose a drunken person is there. When the drunken person is there, how he walks. So he walks with a wide base of support, without balance it is. Okay. So all these are the presentation with the gait. Now we need to assess finally with the functional activities: spine lying, prone lying, crawling, quadruped, sitting, kneeling, standing, etc. Okay, now comes with the what will be the management in terms of physiotherapy aspect. So now if you see the signs and symptoms on the assessment, we are concentrating basically on what category of CP it is there. So suppose it is a spastic CP, that is the main component is the spasticity. So how can we reduce that hypertonicity? So the root cause we need to identify, root problem we need to identify, that will be the major problem which will be hindering the functional activities. So here it is that is the tone, increased tone will be there in the muscle, that we need to control, that we need to decrease it. So what we have in the therapy aspect, physiotherapy aspect, what are the different techniques we have is one of the important is cold therapy, that is the ice application, common ice will be there, no? That application for prolonged period of time. If ice can be applied into different forms. So when I am applying the ice in a continuous period of time, that is called the prolonged icing. So that will have effect on the tone of the muscles. Okay. Then stretching technique. So we need to apply stretches for prolonged period of time, that is more duration. Then that will have an effect on the spasticity. Then passive mobilization exercise, that is passive range of motion exercise. Then slow rhythmic rocking and rhythmic rotational movements like PNF techniques, that will also affect with the spasticity. Then positioning techniques, okay, it can be done by sprinting also or manual also, anything can be. Then weight bearing activities like weight shifting activities. Then active movements, that is active mobilization of all the joints, encouraging the child. Then dissociation of body segments. Then PNF, that is called the proprioceptive neuromuscular facilitation. Maybe it may not be aware and it is very difficult for you to understand. Those with the background of therapy, they can understand all these things. But we have the different types of therapies to decrease the spasticity. Okay, so this is the explanation like how the ice will be effective in decreasing the tone. It's not required. Okay. Okay, all this is the explanation series. Okay, next when you see with the, that is with the spastic CP. When you come with the ataxic CP or hypertonic CP, now here the tone is decreased. The tone is decreased here. Now the target is tone we need to increase. In the before slide, I was telling you how to decrease the tone. Now this slide, we need to see that how the tone we can increase. So we need to facilitate the tone. So this is called as the facilitating techniques we need to use. Like suppose the same icing, before case, I was telling you to apply ice for prolonged period of time. But now I mentioned here it is a quick icing, okay, quick stretching, quick brushing. All these things will facilitate the tone in the muscle. Okay, muscle strengthening, then anti-gravity positioning of the head, trunk control exercises, and stabilization of joints with weight bearing exercises. So now in case of with the acetide CP, the main concentration will be improving the postural tone and balance, then promoting midline and symmetrical muscle control, and small graded movements with resistance, and exercise with the weighted cuffs. So to decrease the involuntary movements. Here the target is involuntary movements. We need to control the involuntary movements. That's why when you see the weighted waist, heavier toys should be given to the child and weight bearing exercise should be given in acetide CP. So midline oriented activities, bilateral symmetrical movements, weight shifting, core strengthening exercise, mirror exercise. These are the examples of exercise in acetide CP. Okay. Functional activities, balance coordination training, proprioceptive feedback, consistent practice with the reinforcement. All these are techniques. Yes, okay, and along with the major conservative treatment, we do have a specific categories. That's what I was explaining in the multidisciplinary approach also. So this is a part of both OT and PT, so what you call as a neurodevelopmental therapy. So this also called as a Bobath approach. So moving through normal movement patterns to experience normal movement. So there are two basic criteria of this entity. So one is inhibiting the abnormal movement patterns, and one is facilitating the normal movement patterns. So what is this inhibiting abnormal movement patterns and facilitating normal movement patterns? So there are movements which are, it is like if you feel that is should be encouraged, then that movements we need to facilitate. And there are certain abnormal movements that we need to inhibit. So there are facilitating normal movement patterns and inhibiting abnormal movement patterns. These are the two techniques. So major components that is called as reflex inhibiting coaches, that is inhibition of abnormal reflexes, normalization of muscle tone, adherence to normal development sequence of motor progression, and improving muscle functional motor skills. So all these are the major components. So inhibit abnormal muscle tone and primitive reflexes. So like as I told you, ATNR, that is 6 to 8 months it is there. After that, that has to be integrated. If it is not integrating, so that has to be inhibited. That's why this entity will be useful in inhibiting abnormal muscle tone and primitive reflexes. And we need to facilitate the normal movement patterns via one of the major technique is positioning, and second one is the handling techniques. So these handling techniques which will be promote the sensation of normal movements. So that handling techniques I can achieve with the shoulder as a key control, or it has can be a pelvis as a key control. Anything we can take into consideration. So and third one is emphasizing on acquiring functional skills. So that is weight bearing, weight shifting, normalizing tone. So these are the important points: weight bearing, weight shifting. So this has to be attained. Like suppose example, if you take with the walking, so what is the important aspect? It is you need to shift the weight from one leg to other leg. We need to take the weight. So weight bearing, weight shifting, and normalizing tone. These are the three criteria of NDT techniques. Okay. Can you see in the picture? The child, we are on the ball, we are taking the child, both the upper limbs on the ball, and then we are keeping the encouraging the weight bearing on the both upper limbs. So this is only he is taking the weight now. So this I can encourage to weight shifting activities also from one upper limb to another upper limb. So this was a dynamic ball. So where the surface is dynamic. Now in this picture, same exercise, we can see that static surface it is. Yeah. So that was one approach. Then we have another technique, that is sensory integration therapy. So here we need to emphasize on importance of, so that is about the sensory system, that is tactile, proprioceptive, and vestibular. So we can make use of all these sensations to encourage the motor development. So through tactile or through proprioceptive or through vestibular. Can you see through the vestibular system, how can we encourage? So this is a part of OT also. And this is with the ball, you can see the picture. And the third therapy is, first was NDT, then sensor integration, and third one is constraint induced movement therapy. So when I said constraint, that is I am constraining the movement, the part of the body. Like suppose example, if you see in the picture, so here the baby is affected with the left hemi or left upper limb is affected, isn't it? So what I am doing here, it is, sorry, here the right upper limb is affected, left upper limb is normal. So I am constraining the movement of the normal side, so that she can encourage with the affected side. So this is called as a constraint induced movement therapy. So this is the another approach. Then serial casting. So this is another technique. It is helpful in reducing the spasticity. And as I mentioned, is serial casting. It is not like one time you need to do casting and then we need to do. So it is a serial casting depending upon the response it is. Then we can use the drugs, that is Botox plus serial casting. Both also can be used to reduce the spasticity. And body weight supported treadmill training, like you can see in the picture here. So because the posture is affected, so I need to support the trunk. So that will be taken over by the harness system of the treadmill. Then the baby can try, we can try for walking. Then we have strengthening up with various equipments like band, TheraBand, dumbbells, weight cups we can use. And assistive devices, in the starting I was telling you, we can use assistive devices depending upon the grading of the CP. Then we can use electric modalities like neuromuscular electrical stimulation, like you can see in the picture here. Okay, and different categories of orthotic devices we can use, like you can see the AFO, where there is a function is lost with the ankle because of increased tone in the plantar flexors. So that can be controlled with the splints. Okay, and we can use other assistive technology So which can facilitate the more normal movement, for alignment, posture and function, and inhibition of spasticity. We can use other techniques also. And this is a modification of equipments. And this is a standing frame commonly used in the CP. The CP standing frame, what you call, where we can encourage the trunk control and trunk stability so that upper limb activity can be encouraged and equal weight bearing can be taken. And this is just with the gliders. Then the wheelchair and hippotherapy. This is again one of the important therapy. So which will stimulate the vestibular activity in promoting with the head and neck control and trunk control and upper limb activities. Okay. And we can go with the aquatic therapy. Again, water plays a major important role in encouraging the function, in reducing the tone, in maintaining the balance, in improving the postural stability. In a number of ways, we can make use of water. That's why aquatic therapy plays a major role in all the neurodevelopmental conditions. Then this is a special type of assist device, what you call a theratongs also can be used to maintain the posture. And next session will be taken care by our staff. So that's a part of speech and language therapy, which is a more important component with the CP. And finally, we need to encourage the functional movements. So this is supine lying position, side lying position, prone lying position, sitting, quadruped position, kneeling position, standing position. So all these are the examples, so which I mentioned here. So this is about with the overall intervention with the physiotherapy aspect. Everybody has to attend all the sessions, and at the end of the session, you need to answer the questions. Once you attain the 70% of marks only, you will be getting the CRE points. So please listen to the sessions and you answer the questions at the end of the session. Last 15 minutes is very important. We need to answer all the questions. It will be taken by the host RCA person. He will be providing with us all the questions, multiple choice questions. We need to answer on online. Okay, it is mandatory. Again, I am repeating. Afterwards, nobody should ask me, I did not get the marks. You have to attend the exam. If you are not attending the exam, you will not get the CRE points. You have to attend the exam. You have to get the marks also 70%. Right? So this is about with the CP intervention from the therapeutic aspect, from physiotherapy aspect. Okay. Next session will be taken by our staff. Lakshmi sir, senior person in the speech pathology. So he'll be taking care of the second session, speech aspects of cerebral palsy. Thank you. Anybody has any doubts? Anybody has any doubts? Okay, we'll share the PPT. Don't worry. WhatsApp group is there. No, in the WhatsApp group, I'll share the PPT. Okay, take a break for 2 minutes. Next session will be taken over by Lakshmi sir. Grand ఒక ఫోటో తీసుకుందాం. స్కీమా ఉంటుంది ఇంట్రెస్టింగ్ ఫోటో అయిపోయింది ప్రింట్ స్క్రీన్ PPT. చెక్ చేస్తే సార్ పాయింట్ రాలే 4 పాయింట్ రావట్లేదా? ఓకే.
వచ్చింది.
కొంచెం
సార్ వాళ్ళు రిజిస్ట్రేషన్ చేసుకున్నాక వాళ్ళు మెయిన్ ఐడి వస్తుంది. పాలసీ అనేది కావాలి.
స్టార్ట్ చేయనా కాసేపు ఆగనా? మారట్లేదు.
సార్ వస్తా సార్ ఒక 15 minutes లో. ఇప్పుడా సార్? ఇప్పుడు రాను సార్. అవును. తీసుకుంటా సార్. ఎప్పుడు సార్ ఇప్పుడు సరే సార్. సార్ యూపీఐ ఈ నెంబర్ ఇవ్వండి సార్. మీ సరే సార్. ఓకే. చేసిన 10 minutes ముందర పెడుతున్నా.
Remember, sir?
Yes, sir.
But ఇంకా ఫోటో కూడా ఎవడు రాలేదు అక్కడ, ఫోటో షూట్ కూడా ఎవడు రాలేదు అక్కడ. ఆడియో నాట్ క్లియర్ అని పంపిస్తుంది వాడు. నాట్ ఆడిబుల్ అని. Right, it's audible. సిగ్నల్ లిఫ్ట్ కావడం ఏంటో. సో బిఫోర్ దిస్ కొన్ని మాట్లాడాలి కదా. రండి కాసేపు క్లోజ్ చేసుకోండి, కాసేపు క్లోజ్ చేసుకోండి. సో రిపోర్ట్ చేస్తున్నాను. Yeah, good morning, all of you. Good morning, all of you. Is it audible? Okay, I am Lakshmaya, speech pathologist and audiologist. We will be talking now regarding speech and language problems, speech, language, voice and hearing problems of children with or persons with cerebral palsy. Yeah, before going to start this actual topic, I would like to mind you regarding speech, language, and as well as communication. Okay, in generally, communication and hearing starts early in life, then language and speech. The hearing starts within the uterus only. The hearing mechanism will be developed within the uterus. As we are Indians, we will be knowing the history of some mythological history of hearing in Krita Yugam and as well as in Dwapara Yugam, Mahabharatam, and as well as in Krita Yugam regarding about Hiranyakashipu's son Prahalada. So was taught by Narada Maharshi regarding the Narayana mantra to Prahalada, and as well as in Mahabharata, which is the baby was within the uterus only, Prahalada also. And in Mahabharata, Arjun was talking regarding the Chakravyuham with Subhadra. And Subhadra was sleeping. After some time, the fetus was giving response while speaking to Arjuna, speaking to Subhadra. So that was the history. So we can understand regarding the hearing development. By first trimester of baby, the hearing mechanism gets developed. Then it starts functioning from that period to till our last breath. So if it is working within the limits, within the hearing limits. So that is the hearing development. And regarding communication development, the communication starts very early from the first day of birth, which is, we call it is birth cry. That is first birth cry. It is a indication for the baby well development and as well as problems with the baby. Yeah, I'll show you slides. I'll show you slides. Just I am speaking. So after first birth, the baby will be learning many things in the language. And by the 3 months of period, the children starts recognizing parents and as well as their name. Okay, so this is the language development takes place and speech will be appear at the age of 1 year. If the developmental schedules are within the limits or within the regular development. So then we can say the speech at the age of 1 year. Whereas when we talk about communication, the communication is a process between the person to person and person to many persons, which is a never-ending process. Communication is. So the listener will be listening, the speaker will be speaking, and the sharing of ideas, feelings, and all will be, and learning something good, new things, and many things will be there in communication. The communication may be two types. One is verbal and another one is non-verbal. The non-verbal things are many things, are many modes of communications are there. Verbal thing is just through speech. Nowadays, people are enjoying non-verbal communication after invention of the smartphones. The persons intentions may not be perfectly not knowing with the non-verbal communications. For example, nowadays people were using more about WhatsApp, Twitter, Facebooks, and Telegrams. Many modes are there for non-verbal communication. The verbal communication is very important because it is dominated by all other communication modes. The person feelings can be expressed in a precise manner with the speech, whereas through writing, through expressing mind, or through doing drama and all, the precisely expression may not be there or may be there with other modes of communication, but which may not be understood by all other people. Whereas language is a system which will be having a rules. That rules will be followed by the language known people. That rules will be different from the Indian language to foreign languages. Whereas Indian languages, we don't use prepositions. While starting the speech, we don't use prepositions majority of the time in Indian languages. In poetic languages, generally we use the prepositions in Indian languages. But whereas in foreign languages, they will be starting with the prepositions majority of the time. The speech is a verbal codes. Speech is a verbal codes. The commonest codes are spoken words. These spoken words will be learned by the children with their native language and foreign language. Nowadays, children are learning at a time 2-3 languages. So knowing many languages, it's a good for the personal development as well as for the communication through speech. The children with cerebral palsy, I'll be presenting the PPT. Children with cerebral palsy, they will be facing speech and as well as language and communication problems. Just cerebral palsy, no association problems. We can expect that there is only speech problem. If there is associated problems like hearing loss, ID, and visual impairment, so there will be a problem in learning language. So we will be providing assistive devices to improve their vision and as well as for the hearing. Then we will be introducing the language, speech and communications. Okay. Go to yeah, now I am presenting the PPT. Speech and language disorders in cerebral palsy. Cerebral palsy can cause a variety of different disorders. One of the most common is a speech disorder. If there is no other associated problems. So according to estimates, anywhere from 50 to 70% of individuals with CP have some type of speech impairment. But speech impairment is many types in children with cerebral palsy. So 50 to 70% of children with individual with CP may have one or the another impairment in speech, not visible. Visible only. PPT is visible. Just check your system. Windows place. Okay. Okay, so 50 to 70% of individuals with CP have some type of speech impairments. There are many types of speech impairments with cerebral palsy, but 50 to 70% of individuals with cerebral palsy have some type of speech impairment. That may be slow rate of speech, that may be nasalized speech, that may be laborious speech, that may be unintelligible speech, that may be misarticulated speech, and some sort of voice problems. Majority of the time we can see voice problems are hoarseness of the voice. The severity of these impairments can range from mild to severe, and they can impact an individual's ability to produce or understand speech, produce and understand of speech. Cerebral palsy can impact speech and language development in a number of ways. For example, difficulty with muscle control can make it hard to produce clear speech sounds. When the muscle coordinations, especially oral muscular coordination and the tongue muscles coordination, lip muscles coordination, and as well as laryngeal muscles and lungs muscles. These are all coordinated for speech. In this chain, if any one of the muscles are not coordinating during the speech, so there can be some sort of speech problems will be there in the children with cerebral palsy. The cerebral palsy can impact breathing also. This can also lead to problem with speaking. And some children with cerebral palsy having swallowing difficulties. Eating and drinking problems as well as these all come together and these all will be creating a problem in speaking. Majority of the children you might have seen with cerebral palsy, there is a drooling, salivation. Salivation, when it is occluded within the mouth, so there is an incoordination of the tongue muscles and lip muscles. So tongue is the major organ in speaking, in speech. The movements of the tongue is not coordinated or incorrect or inadequate, so there will be a problem in the speech. One slight problem with the tongue is tongue tie. Even if you are having no cerebral palsy, the frenulum which is connected to floor of the mouth and tongue, the base of the tongue, if it is short in a length, there is also speech problem in saying some sort of sounds, some sounds like retroflex sounds, like ra, and lateral sounds la, and palatal sounds ta, da, and nasal sounds na. So these sort of the speech sounds are problematic children with tongue tie, even if they are having no cerebral palsy and no intellectual disability and no hearing loss at all. Everything is perfect, but only the small problem is with tongue is a tongue tie, ankyloglossia. So whereas in cerebral palsy, the entire muscle coordination is disturbed and affected. The speech requires finest coordination in the human body. So when there is a gross motor difficulty, is a creating problem in walking and all, picking the things, holding the things. But when we talk about speech, it needs very fine motor coordination, very fine, which is a topper in the coordinations of the muscles in the human body. Topmost priority for the muscle coordination required for speech production. The speech production muscles are in a chain from lungs to the external parts. Last part are the lips. Child with cerebral palsy with open mouth and drooling. So it is difficult to produce bilabial sounds, which are learned during the babbling period. So that is also a problem for children with cerebral palsy. It is easy sounds. There are easy sounds in speech and language development as well as in expression. So which are also a problem for the children with cerebral palsy. While each child with cerebral palsy is unique, some common speech and language disorders can occur. These include apraxia. This is a motor disorder that impacts the ability to produce speech sounds. Cerebral palsy can cause problems with muscle control, making it hard to produce certain sounds. Just now I am saying child with drooling and open mouth. So it is the apraxia of the lips, which are may not be coming together to produce bilabial sounds, labial sounds, and labiodental sounds. For example, pa, ba, ma, which are all called bilabial sounds. Va, fa, these sounds are called labiodental sounds. So, which majority of the speech sounds is a problem with cerebral palsy to produce due to the apraxia and as well as dysarthria. This is a motor disorder that impacts the ability to speak clearly. This is a motor disorder that impacts the ability to speak clearly. Means the intelligibility of the speech is get affected because of the motor incoordination. The muscles involved in speech production may be weak or have poor coordination. This can make it hard to produce clear speech sounds. When the tongue movements are inadequate or weak or poor coordination, the coordination between palate and as well as tongue, palate muscles and as well as tongue muscles. So there is a problem in producing majority of the speech sounds. Only sounds, the pa, ba, ma is not required tongue movements. But majority of other speech sounds, remaining other speech sounds require tongue movements. Even for vowel sounds also, we need tongue movements. Tongue is may not be contacting any other articulator, but it's giving shape to the oral cavity while saying vowel sounds. Because of that, the tongue is very essential organ in producing speech sound, a combination of speech sounds as well as conversation and narration. When the coordination is weak or a poor coordination, so it's very difficult to produce even single sounds like ka, ga, na, ta, da, ta, ta, cha, ja. These are all phonemes, single phonemes. If coordination is inadequate or poor coordination, the muscles are weak, so producing these speech sounds, even individual speech sounds, it's a difficult for children with cerebral palsy. As you know, that there are a four types of dysarthrias. First one is spastic dysarthria, flaccid dysarthria, ataxic dysarthria, mixed dysarthria, hypokinetic dysarthria, and hyperkinetic dysarthria. The spastic dysarthria, which is a major problem in children with cerebral palsy. This type of dysarthria is common among those with cerebral palsy. It is caused by muscle spasms that make it hard to produce clear speech sounds. When the muscle spasm is there at larynx, the laryngeal muscle spasm is there. First problem is generation of the voice occurs, and after struggling of that, there may be generation of voice. That voice will be entered into the oral and nasal cavities. Again, that voice have to be amplified and resonated within these oral and nasal cavities. If these muscles also get affected, then again there will be a problem in the intelligibility of the speech, intelligibility of the speech, and as well as misarticulation of the speech will be there. The flaccid dysarthria. This type of dysarthria is caused by weak muscles. It can make speech sound slurred and mumbled. The spastic dysarthria, the speech is slow and also slurred. The flaccid dysarthria also there is a slurred or mumbled speech. Ataxic dysarthria. This type of dysarthria is caused by problems with muscle coordination. This can make it hard to produce clear speech sounds as well as make it hard to control the volume and pitch of the voice. The volume increases in oral and nasal cavities because of the amplification. If the volume is reduced within the oral cavity and nasal cavity, there is a low volume, means inaudible speech, and as well as the pitch of the speech will be get affected. Mixed dysarthria. This type of dysarthria is a combination of two or more of the above types. So those type of speech problems may be there, maybe slurred speech, slow speech, mumbled speech, unintelligible speech, low volume speech, low intensity of the speech, and pitch problems. So these can be affected in mixed dysarthria. Hypokinetic dysarthria. This type of dysarthria is due to lack of muscle movement. It can make speech sounds very slow and monotonous. The monotonous voice, there may not be any change in intensity of the voice. The raising pitch, falling pitch, so these are will be there during the speech. But monotonous voice and monotonous speech, there may not be any raising and falling of the intensity during the speech. So that can be visible or that can be audible, that can be observed in hypokinetic dysarthria. Hyperkinetic dysarthria, this type of dysarthria is due to too much muscle movements. It can make speech sounds very rapid and irregular and misarticulated. So these are the major speech problems will be there with children with spastic dysarthria. Yeah. Cerebral palsy, not spastic dysarthria, cerebral palsy. Like hard to produce a clear speech sounds and a slow rate of speech and slurred speech, mumbled speech, okay, low intensity of speech, low volume of speech, pitch problems, and as well as voice problems, slow rate of speech, and monotonous children with cerebral palsy. The dysphonia also one thing is there with children with cerebral palsy. Dysphagia also may be there, and as well as cognitive impairments also can be observed in some children with cerebral palsy. Dysphonia, this is a voice disorder that can cause hoarseness, breathiness, and pitch problems. Cerebral palsy can cause difficulties with the muscles used for breathing, which can lead to problems with the voice. Okay, generally, the voice problems in children with cerebral palsy, say hoarseness, breathiness, and nasal voice can be observed majority of the time in children with cerebral palsy. Dysphagia, this is a one type of swallowing disorder that can make it hard to swallow liquids or solid foods. Dysphagia can also cause choking or aspirating, breathing in liquids or food, solid food. This can lead to respiratory infections or pneumonia. Children with cleft palate can be seen these characters like choking and aspirating liquids and food. The same thing can be observed in children with cerebral palsy, which may be leading to respiratory infections and as well as pneumonia. During the developmental periods, if this pneumonia recurrently occurring, so there may be chance in brain damage. So which will be again leading to ID. intellectual disability. Some cognitive impairments in cerebral palsy associated with cerebral palsy can also impact language development. So before this, we were talking about the speech and voice problems. Now, if there is a cognitive impairment, there can be impact on the language development. These impairments can make it hard to understand or process spoken or written language. There is a associated problems with cerebral palsy like ID and hearing loss, which is again making those people to more problems in learning language and as well as expression of speech. These impairments can make it hard to understand or process spoken or written language, the cognitive impairments. Additionally, they can make it hard to remember words or to come up with the right word when speaking. So the remembering of the words which are very essential for communication, speech communication. If there is a cognitive impairments like ID is there, then there is a lot of forgetfulness will be there in the children with ID. So that will be creating problems in remembering words and as well as speaking the single words. Speech therapy treatment for people with cerebral palsy. The type of treatment will vary depending on the individual's needs. Some individuals may only need a few speech therapy sessions, while others may need ongoing support. For example, children with cerebral palsy, if they are not associated with other problems, and mild cerebral palsy, children may require some sessions of speech therapy for improving their clarity and improving their articulation and improving their projection and improving their voice quality and volume of the intensity of the speech or volume of the speech. Children with severe cerebral palsy, they require ongoing support for years together. The treatment may involve exercises to improve muscle strength and coordination that are tongue muscles, oral muscles, lip muscles, and as well as lower jaw muscles and lungs muscles, as well as laryngeal muscles. So these muscles get into coordination. So then there is a good expression of speech sounds, a speech, a narration of the speech will be there. The internal muscles, so we may not be going to do something with the respiration. There is a breathing exercises can improve lungs muscles and swallowing exercises, assistive devices or augmentative communication devices, cognitive linguistic therapy, the social skill training. So majorly they require these sort of the therapies, children with cerebral palsy. The tongue muscles exercises generally as a physiotherapist, you may be knowing the pulling out the tongue and taking back and moving sides right to left and left to right, and lifting up and keeping down, and rotation clockwise and anti-clockwise. So these are the tongue exercises. Each individual is unique with cerebral palsy. The unique individual requires the exercises uniquely, and lip exercises, oral pressure building exercises, oral air pressure building exercises, oral water pressure building exercises, blowing exercises, spitting exercises. So these are all general exercises which are helpful for the children with cerebral palsy. And practice producing speech sounds. The therapist, while giving speech therapy, the therapist will be showing his tongue movements and the contacts to each other articulators precisely and with visual biofeedback, or making the person to sitting opposite to therapist. So while producing the bilabial sounds, the therapist will be showing his both the lips and making the child to observe his lips and producing his speech sounds. While producing pa and ba sounds, the upper and lower lip should come together, and there is a air pressure building behind the lips, and there is a sudden release of the airstream, and the explosion of the sounds will be there with the bilabials. And some speech sounds will be explosion, some sounds will be laterals, some sounds will be retroplex, some sounds will be blocking of the air, some sounds will be liquids. So many types of speech sounds are there. But any speech sound which requires the muscle coordination of the oral cavity. So because of that muscle coordination, inadequate muscle coordination, the speech production is a problem for children with intellectual disability. The breathing exercises, regular breathing exercises, which can be helpful in improving muscle coordination of the lungs and as well as larynx. Both inspiration and expiration exercises, both are helpful for the improving of the laryngeal exercises, laryngeal muscles, and as well as vocal cord muscles. Then swallowing exercises. The digital manipulation can be applied for swallowing exercises where the persons with hypertonic, for example, the male children at adolescent age, they may be speaking like a high pitch voice or female pitch voice. So that can be treated with digital manipulation and as well as other techniques. That digital manipulation can also helpful in swallowing. Then assistive devices. The speech is not at all possible for a child with cerebral palsy. So some sort of assistive devices can be introduced. One is the headband with pointer. The child will be typing with head on a system for communication purpose, whatever he requires for regular and special needs, and as well as for the communication. The child will be typing with that headband, with the support of that headband and the pointer. And the words will be visible on the screen of the system or laptop. So that can be one sort of assistive devices. Then augmentative communication devices. Children with hearing loss, they need some sort of amplification systems which are helpful in improving his hearing. And children with cerebral palsy without ID associated with hearing losses, they can be suggested cochlear implants when there is a no intelligence problem, intellectual disability. So we can recommend cochlear implants to improve his hearing to maximum extent, so which is very helpful in learning language. So which language leads to speech and speech leads to verbal communication. So because of that augmentative communications, many types of hearing aids are available. And when there is a motor coordination, it may not be possible for alternative communication. The children with cerebral palsy, they are suffering with finger coordination, hand coordination. So the alternative communication is majority of the time it is not suggestive. And cognitive linguistic therapy, the language learning therapy, it is language teaching therapy. When there is a cognitive problems are there, children with the cerebral palsy and associated problems, there is a linguistic therapy is required, which is vocabulary development and parts of the language development will be introduced in the cognitive linguistic therapy, and which requires years together training. So depend on the severity of the cerebral palsy and as well as intellectual disability. But both the severities, intellectual disability and cerebral palsy, both are severe. So we can expect a limited language, a limited vocabulary, a limited speech. So finally, we will be introducing social skills training. The social skills training, which is essential for day-to-day life and professional life, sharing of feelings and ideas. The social skills training in communication, asking questions, giving answers to the questions, and as well as explanations, narrations. So these are all required as social skills of communication, which are very essential nowadays. If you speak more and more with relevant speech, things will be getting completed. If you don't speak, even you are speculative, so your work will be somewhat, it is delayed. Nowadays, you are speculative, the works will be completed faster and faster. So the below one spastic children's speech characters, I was explaining you. Just once again, there is a slurred speech will be there and harshness of the voice will be there. And their speech is very laborious and effortful speech will be there in the spastic children. But these are the techniques which are used for improving speech communication in children with cerebral palsy. So by here, I am going to end my session. And from your point of view. Would you like to ask me anything? Here, you please. Any suggestions, any questions? Participants, shall I close my session? Or do you want to ask something? Or suggest something? Nobody is responding, means you are not attending. Please explain linguistic therapy. Teaching language, in general, it is nothing. Teaching language, which are the parts of the language. In general, I am saying parts of the language. The many parts are there in the language. Teaching those all parts of the language may be called it is a linguistic therapy. Means it is development of the vocabulary, which requires for communication through speech. As we know, there is a nouns, verbs, pronouns, adjectives, adverbs, and singulars, plurals, articles, gender. So these all will be there in the language. So teaching these all parts may be called as linguistic therapy. Language teaching. Anything more, please? I am closing my session. Thank you very much, participants. So take 10 minutes break. Hello, sir. We'll be meeting by 12:10. Okay. Okay then. Now,
ఇది సిస్టమ్ లో సేవ్ చేసి
see, one person is responding. Then it is 3 persons. Take it.
చాట్ బాక్స్ में అక్కడ పైన
Into ఎదురు
ఇక్కడ లేదు కదా పెన్ డైరెక్ట్ తీసేయాలి
एक मिनट सर कर्सर कहाँ है सर ये देखो अब आएगा हाँ ये यहाँ पे अब
विजय कर दो।
ये है ना
हाँ
यस
भैया
अरे वो के नेल्स इतने बड़े बड़े हैं नेल्स
काटना है।
अच्छा इसमें से लाए
लड़कियां बहुत सता रही हैं काटने के लिए।
मैडम को ये काट देंगे ना तो ये लक्ष्य कुछ भी नेल कटा मेरा बेटा एवरी संडे कंपल्सरी
Sound చేసి బయటకు सेशन के द्वारा ये विंडोज तो मैं एक
कौन सा?
विंडोज
ये विंडो एंड
ये प्रिंट
अच्छा, उससे क्या होगा?
फोटो फोटो
अच्छा, साउंड म्यूट नहीं है
करना था आपने
ओ असली वाले क्या पूरा कर रहे हैं सो that person is also here. Last time भी थे वो ना. नहीं ऐसे ही बैठ ठीक है. एक यतींद्र सर का हुआ, एक अभी लक्ष्मैया सर का और लास्ट 3 सेशंस है 3 hours ना. शुरू करें फिर 10 minutes ब्रेक बोला हमने. Training videos and idea. Training candidates select the one all over India. Another states के बच्चे हैं उसमें से एक कोई कॉलेज में अच्छा कॉलेज स्टार्ट करता परमिशन भी है मैंने एक संपूर्ण रहा था और सो लेकिन इस बात में तो तीन नहीं था सर्वे परमिशन पकड़ के डिस्प्ले को लिया पहला क्या होगा मैं फाइनेंस में क्या पढ़ना है पसंद में है ये मैं then bio Jadi bagaimana seperti apa yang sama dengan itu? Dari seperti mana yang dari sampai di mana? Nih, kita mesti berbicara itu seperti ada yang macam yang yang perasaan lain sebenarnya sudah berubah. पढ़ेंगे tapi dan itu tidak diperhatikan. Kalau ada setiap harus seperti ada seperti yang harus seperti Example, was graduate college. When I started, who would like to be, yeah, sorry. Yes, can be one of the profession. So, here now, I am doing yes, say, for conflict. Yeah, we are going to clear continuous. Very good, actually, of this one. Like, independently, Suddenly, to independent we will be started. The This is a very big experiment to answer the lab, to answer the start in front of when job and the why not as a content to be able to as an apprentice Shri Lakshmi Vijoli ke वैसे ना होते उससे बढ़िया तो मुझे कुछ सीखते हैं तेलंगाना में भी ऐसे जबरदस्ती नहीं करते ना हमारी वो है हमारी लेकिन हमारी इच्छा से ना है जैसा बोले मैं बोली आप बिजनेस ऐसा पैसा कितना हमारे सामने कुछ ऐसी बात कर रहे हैं हिंदी में इधर तो हिंदी में हिंदी में डाल आगरा में इसका क्या करना है अच्छा मेरा ही नहीं वो क्या है देखो
पे जॉब अच्छा मुझे नहीं आता तो आता
फिर कैसा
मैं सर के बोला आप टीच आप इंट्रोडक्शन
राहुल हाय राहुल Yeah. Good afternoon, participants. अच्छा, okay. Okay, okay. Okay, right. All right. I am occupational therapist. My topic is aspects of occupational therapy and sensory integration in cerebral palsy. So you all know what is cerebral palsy. Already it is done, I think. So what is the role of occupational therapy in cerebral palsy? Occupational therapy is an art and science of directing man's participation in selected tasks to restore, reinforce, and enhance the performance, to facilitate those skills and functions which are essential for adaptations and productivity, to diminish or correct pathology, to promote and maintain the health. For example, like in cerebral palsy, we are getting sessions on cerebral palsy. So the role of OT is to reinforce and enhance the performance of the person with cerebral palsy, to facilitate their skills and functions by using adaptive devices or splints, by suggesting them splints or orthosis. And at the end of the day, our goal is for productivity. The person should be independent in their self-help skills and in their activities of day-to-day programs, and to promote and maintain the health. Occupational therapy is a skill treatment for the persons with neurological disorders, help them to become independent in their skills of daily living and occupation or work. The main concern of the OT is activities of daily living. Like for the children with cerebral palsy, activities are like brushing, bathing, dressing, eating, buttoning, unbuttoning, lacing. Then writing skills means holding pencil. Then their ambulation, walking. If they need any splint for maintaining the proper position of the hand, so the occupational therapist can suggest them about the splints for the hands for proper movements. So these are the concerns. Occupational therapy is primarily concerned with ensuring the health and well-being of the individual in their living environment. Occupational therapy is concerned with individuals' functional development in each of the several dimensions like physical, psychological, cognitive, emotional, and career. In our occupational therapy assessment, we take the assessment of gross motor, fine motor, then oral motor functions, and also we take the intervention, we take assessment like play skills of the children, their writing skills, and their neonatal reflexes. The assessment process. Assessment process provides the baseline for the intervention and often focuses on identifying and defining an individual's priorities and the factors that enable or limit his or her occupational performance. For example, if the child with cerebral palsy, diplegic cerebral palsy, the child is not able to walk, but he can use his hands functionally for performing his daily task like eating, drinking. So what are the priorities for the child? First, he has to do his ADL skills properly. This is the priority. Then, which enable his limits is for the occupational performance. So by doing his hand functions independently, the child can do his other skills by self. In addition to the information gathered from the people, the assessment is also based on information derived through the observation, questionnaires, and appropriate standardized and often dynamic evaluation. We get the... Okay. Now... So while taking the assessment also, we observe the person or the children. We observe about his movement, about his hand functions and his capabilities. Why? Because the main role of the OT is we find out first what the child or the person can do. What are his abilities? According to that, then we can give them the activities to improve their functional skills. Primary aspects of occupational therapy assessment. As the occupational therapist observes the person's performance, therapist attends primarily to the aspects of performance skills such as motor skills. What is the position of the child? How is stability and how the mobility is. Then processing skills like attention, initiation, choice or organization of the time and space. Then communicative skills, establishing eye contact, cooperation, or the methods of expression that are utilized. how the child is communicating with other people by gesture, whether the child is verbal or non-verbal. If he's non-verbal, whether he is communicating by gestures, does he makes eye contact or not? How his cognitive skills, whether the child is able to understand others' instructions or not. Occupational performance analysis together with the assessment data collected are used to determine the focal points of the intervention. So the role of OTs in developmental and motor performance, like fine motor skills, gross motor skills, visuomotor skills, then oral motor skills, activities of daily living. Then for performing activities of daily living, the person should have proper, or the child should have proper eye-hand coordination, thinking skills, visual skills, sensory skills. We are able to do our daily living skills with our sensations. So sensory skills are also important for the cerebral palsy children or person. Then we suggest them for wheelchairs or other adaptive equipments, whatever they need for their performance. Then postural control and positioning, range of motion, strength and endurance. Occupational therapy checks the following sensory motor components. The sensory motor components are muscle tone. Generally in cerebral palsy, the child may have tightness, spasticity in their muscle tone. It is also called as hypertonicity. Then muscle strength, whether the child is able to lift weight, carry, push or pull weight or not. Then muscle endurance. Muscle endurance is the muscle strength for the repetitive actions like cycling or swimming. Then range of motion means movements, coordination and balance, posture and hand functions. These are the examples of occupational therapy interventions. Personal hygiene, eating, dressing, instrumental activities of daily living such as preparing a meal or managing finances. Other areas are like work, play, learning skills, social participation, sensory processing, accessibility and environmental modifications, and assistive technology.
Yeah.
I'm okay. So the main role of OT with cerebral palsy children or person, it is in ADL. So we take assessments in the activities of daily living areas. The purpose is to assess ADL performance skills, to determine the problems that interfere with independence, determine the treatment objectives and provide training or equipment to enhance the achievement of higher level of independence. Again, then physical, cognitive, emotional functions also, evaluation is there, which are interfering with the ADL performance. I want to give you the example. I work here in NIPED, Secunderabad in early intervention department. So we see the cases of cerebral palsy in children. Generally, when the child comes, we assess. I assess the child and I assess first I ask the question to the parents regarding the ADL skills of the child. Whether your child is able to hold brush or not. If he's not holding, then we should check about the muscle strength, muscle tone. Whether the child is having hypertonicity, spasticity or hypotonicity means floppiness. Because in cerebral palsy, the child may have spasticity or may have hypotonicity means floppiness. So if the child is not able to hold brush, maybe his muscle tone is hypo or hyper. If the muscle tone is normal, then why he is not able to hold the pen, hold brush? Maybe he is not having proper muscle strength or he is not having proper coordination. There should be a coordination from the brain to the body. So we should find out about the coordination. Then whether the child is able to understand the instructions. If he's having good cognitive skills, understanding skills, the child is able to follow the instructions. So these are some factors which interfere with the ADL performances. So what is the definition of ADL? ADL includes mobility, self-care, management of environmental hardware and devices, communication and home management activities. Then again it is, there is a subclassification of this. Mobility includes movements in bed, wheelchair mobility, transfers, indoor ambulation with special equipment, outdoor ambulation with special equipment, management of public or private transportations. Self-care includes dressing, feeding, toileting, bathing and grooming activities. Management of environmental hardware and devices includes the ability to use telephone, keys, faucets, light switches, windows, doors, scissors and street control signals. These are all our activities of daily living. Then communication skills include ability to write, read, type or use a telephone, tape recorder or special communication device. Home management activities include marketing, meal planning and preparation, cleaning, laundry, child care, ability to manage household appliances such as vacuum cleaner, can opener, refrigerators, electric mixers and hand operated utensils. Factors to consider in ADL evaluation. While doing evaluation in ADL skills, what factors we should consider? Before commencing ADL performance evaluation and training, we must assess the performance components and consider several factors about the client and his environment. Physical resources such as strength, muscle strength, his range of motion means movements, coordination, eye-hand coordination or hand-to-hand coordination, sensations, we should have proper sensations, tactile sensations, thermal sensations, touch sensation, and of course balance. So it all should be evaluated to determine the potential skills and deficits in ADL performance. So after this evaluation, we can find out, okay, these are the problems which are interfering, these are the factors which are interfering in ADL functions of the child. Then need for special equipment. If the child is having tightness in the wrist joint or if he is not having proper grip, poor hand grip or poor finger grip, we can suggest them adaptations for holding spoon or holding brushes and other equipments. Then perceptual and cognitive functions should be evaluated. It is very important. Perceptions, tactile perception, auditory, visual perception, spatial perception, the sensation of in the coordination in distance, then cognitive functions, understanding. The person should follow our instructions. He should understand the instructions. It should be evaluated, which is the potential for learning ADL skills. Then general mobility in bed or wheelchair or ambulation should be assessed. In addition to this, relatively concrete and objective evaluation, we should be familiar with the client's culture and its values, more in relation to self-care and the seek role or family assistance. The values of the client, his peer group and his culture, it should be important considerations in selecting objectives and initial activities in ADL program. The balance of the activities in the client's day, which demand his time and energy, may influence how many ADL may be performed independently. The type and the amount of assistance available in the home environment must be considered if appropriate caretaker is to receive orientation and training in the appropriate supervision and assistance required. The finances available for assistant care, special equipment, home modifications are important considerations. For example, why it is all important: culture, finances, caregivers, caretakers, and family support. For example, a wheelchair-bound client who is wealthy, he may be willing and able to make major modifications in home, such as installing an elevator, lower kitchen counters, widening of the doorways, replacing the deep pile carpeting to accommodate a wheelchair lifestyle. But his less well of the counterpart may need the assistance in making less costly modifications, such as removing scattered rugs and door sills, installing a plywood ramp at the entrance, replacing the bathroom door with a curtain, and attaching a handheld shower head to the bathtub faucet. The ultimate goal of any ADL training program is for the client to achieve his maximum level of independence. This is all evaluation, then training, intervention is all for the ADL training is all to achieve the maximum independence of the client. It is important to note that maximum level of the independence is defined differently for each client. For the client with mild muscle weakness in one arm due to the peripheral neuropathy, complete independence in ADL may be his maximum. Because the level of the independence, it depends on the severity of the spasticity, cognitive skills, then perceptual skills of the client. While for high-level quadriplegic, feeding and oral hygiene activities with devices, assisted devices, may be the maximum level of independence that can be expected. Therefore, the potential for independence should be based on each client's unique personal needs, their values, their capabilities, their limitations, and environmental resources. Independence is a strong value. It should be pursued. It should not be pursued for its own sake on that basis or because it is the value of rehabilitation personnel or family or the friends of the client. So these are the list of ADLs like wearing clothes, then trousers, stocking, night clothes, then house coat, bathrobe, then jackets, belt, hat, coat, sweater. These are all regarding dressing and undressing. Then regarding hygiene, blowing nose, washing hands and face, washing extremities, brushing teeth, brushing hair, combing hair, cleaning their fingernails, trimming fingernails, toenails, applying deodorant, then shampooing hair, use of the toilet paper or sanitary napkins. This is all hygiene, ADLs regarding hygiene. Then communication skills are verbal communication, reading and writing, holding books, turning pages, writing, use of telephone and typing on the systems or then after the evaluation in all the areas of each and every area of the ADL, we should record the progress during while giving the training in the ADL performances. We should record the progress in the ADL performances. The ADL checklist used to record the performance on initial evaluation usually have one or more spaces for recording changes in abilities and results of re-evaluation during the training process. The progress report should summarize the changes in the client's abilities and current level of independence and estimate the client's potential for further independence, his attitude and motivation for ADL training and future goals for the ADL programs. It is sometimes necessary for the therapist to design a special device, special methods or splints or the piece of equipment to make a particular activity possible for the client to perform. Then accessibility and environmental modifications like changes in the environment, like widening passageways, modifying the playgrounds or adding symbol signs. Then in the equipment such as adapting sitting systems in adapting feeding aids or the tasks such as changing the complexity of the instructions or dividing a task into sub-stages. We should make some changes according to the requirement for the person. We can widen the doorways, passages. We can modify the playgrounds or we can add symbol signs. Then in equipments also, like in special equipments, orthosis, we can make adaptations in for holding the spoons or brushes for the toothbrushing. Then
we should divide the instructions for each and every ADL activities in a simple ways. We can subdivide the steps of the ADL activities. Then assistive technology is one method used to adapt the environment and includes modifications in switch system, communication device, environmental controls, computer software, and mobile device. Some examples are wheelchair, scooter, walker, canes, crutches, orthotic and prosthetic devices, hearing aids to help people hear or hear more clearly. Assistive technology allows for the modifications of individual's environment in the manner in which he or she requires by relating to his personal abilities, wants, areas of interest, and specific limitations and difficulties. Learning skills. The goal of occupational therapy in learning skills is to provide good fine motor skills, pre-writing skills, visuomotor skills, hand coordination, proper pencil grip, then for improving finger dexterity function and improving learning skills in playgroup activities. Then there is a role of occupational therapy in sensory integration also. So the sensory integration is a process by which people register, modulate, discriminate sensations received through sensory systems to produce purposeful adaptive behaviors in response to environment. Why sensory integration is important? Because we receive the information from our environment or surrounding, we organize it, and we use it as a proper response to the stimuli to participate in our day-to-day life skills. So sensory system, rather than our 5 senses, we have 3 more senses: vestibular, proprioception, and interoception. So the 5 sensory organs associated with each sense, they send information to the brain to help us understand and perceive the world around us. Internal sensory and perceptual systems exist in humans, including vestibular, which we receive through our inner ear. It provides a perception of spatial orientation. Then proprioception is the body position, which we receive through our joints and muscles of the body. If there is a problem in sensory integration, we called it as a sensory integration dysfunction or sensory processing disorder. So in sensory processing disorder, there are the problems like sensory modulation disorder, dysfunction of sensory discrimination, vestibular processing disorder, and praxis disorder. So what is sensory modulation disorder? Tendency of the system to generate responses that are appropriately graded to the incoming sensory stimuli rather than over or under reacting to them. Most of the children, they are hypersensitive or hyposensitive. If the person is or the child is resisting for any stimulation, it means he is hypersensitive. If the child is seeking, he seeks those sensations, those stimulations, it means the child is hyposensitive. Tactile defensiveness, gravitational insecurity, aversive response to the movements, and sensory dormancy. These disorders are mainly characterized by negative reactions to hugs and touch experiences, difficulty standing in line, dislike of messy play, hard time with hygienic routines, car sickness. These are the examples of sensory processing disorders. Then what is sensory discrimination dysfunction? It refers to inefficient and inaccurate organization of sensory information. This dysfunction caused due to central processing error. It results from difficulty in perceiving spatial and temporal relationships among the stimuli. Vestibular processing disorder, it refers to disorders resulting from the imbalance among excitatory and inhibitory vestibular mechanism. Then what is praxis? Praxis is any motor action, any new motor action. So the problems with praxis, it includes hypotonia, poor proximal joint stability, poor writing and equilibrium reactions, and indeficient bilateral integration or sequencing. So dyspraxia is a difficulty in planning and carrying out non-skilled actions, non-habitual actions in a correct sequence. It is caused due to the deficient action plan, and this disorder is characterized by clumsiness, awkwardness in the movements. Then the child will have poor transitioning problem. Transitioning means from one activity to other activity, the child will not accept that change, sudden change. then he will prefer for the stereotyped behavior or stereotyped actions. And because of this, the child or the person will have excessive delay in activities of daily living. Then the one more concern of the OT is the hand functions. So hand functions. The hand is very specialized organ that functions to obtain information and execute motor acts essential to human interaction with environment. The ability to use hand normally requires sensations, mobility, and stability. The proximal joints of upper limbs are essential to normal hand functions. We should have proper joint stability at shoulder joint for the movements for the hand functions, for reaching. Then elbow should have the proper abilities for making adjustment in the movements, and wrist should have proper joint stability and the movements for holding and releasing the objects. So there is a big role of the wrist joint, elbow and shoulder joints. It should be capable of stability and mobility for the maximum hand functions. Splinting is one of the several therapeutic modalities that has its aim for maximum restoration of the hand functions and appearance. Splints are made of high and low temperature thermoplastic materials. Splint is the adaptive device. It is a supporting device for maintaining the proper position of the hand or to prevent deformities or contractures. Splints are usually used in treating temporary conditions of the muscle weakness and joint limitations to prevent or correct deformity, substitute for lost muscle power, assist weak muscles in normal pattern of motions. The functions of the hand is prehension and grasp. There are different types of grasp. Palmar prehension, lateral prehension, cylindrical grasp, spherical, hook grasp or span grasp. Tip to tip means fingertip. For example, to pick pins or nails or buttons, it is a tip to tip prehension. Palmar prehension, when we hold small cubes, marble or pen, it is a palmar prehension. Lateral prehension, example is carrying a plate or holding a teacup or turning a screw. Cylindrical grasp is, example is holding a glass or tumbler or hammer. Spherical grasp is a ball grasp. When we hold a tennis ball, it is a spherical grasp. When we hold handle of the bag or briefcase or bucket, it is a hook grasp. Span grasp is when holding a big plate with the palmar surface of the hand or holding a saucer. These are the pictures of hand functions: cylindrical, tip to tip, hook grasp, palmar, spherical and lateral. Adaptive devices, it is already over. So these are some examples of this is a splint, anti-foot drop splint in blue color, and there is a wheelchair. These are the modifications with the adaptive chair for the child to improve his hand functions and to perform his ADL skills in eating, writing, or we can train the child by improving his hand functions for his ADL skills for future. And these are some adaptations in holding spoon with universal cuff, brush with universal cuff, and there is a page turner for the pen holder. Adaptive device is there. Modifications, nail cutter with the adaptation, writing device with the adaptation, then some adaptations in the spoons also, in fork, then plates with plate guard, modified cutting board, jar opener, knife with the modifications, then toilet cleaner with the modifications. The purpose is the person should do all these actions by self with maximum independence. Then zipper, bottle opener, modified door knob, tap openers, dressing stick, reacher. And again, these are some other examples. So participants, my session is completed in occupational therapy and adaptive devices. If you have any questions, any doubts, you can ask. My session is completed.
Sir, ma'am, క్వశ్చన్స్ అతను అడుగుతారు ఆన్సర్.
Shish, they are sending some questions. Oral motor exercises someone has asked. Oh, kitana CRE point milenge, that also they are asking. One question is there.
How do you
Oral motor
feeding skills?
feeding skills. Poor oral motor. हाँ. तो मुझे वर्बली बोलना है ना उसका आंसर.
Just keep that question.
किधर है बेटा क्वेश्चन? How do you work on feeding skills for children with poor oral motor, oral muscle tone? किसी ने पूछा उसका नाम भी लेना है क्या? नहीं ना?
Somebody asked.
अच्छा. Participants, there is one question. One query is there. How do you work on feeding skills for the children with poor oral muscle tone? So for poor oral muscle tone, you should give the oral massage to the child. I don't know what is the age of the child you have asked. You should give him oral massage on his gums, upper and lower gums, then on the tongue surface and inside of the cheeks. Then you should give the activities like blowing whistle, yeah, blowing with thermocol balls, blowing paper pieces, yeah, balloon, candle, and one more activity is there. You should ask the child to suck water or homemade fruit juice with straw. So use of the straw and blowing exercises, it will improve the muscle tone of the oral muscles. And you should give the massage inside of the mouth and also outside of the mouth also. On the cheeks and on the chin area, you should give massage in clockwise and anti-clockwise direction. They can see me here.
Yes.
You should give the massage. You should use lubricator. You can use a talcum powder or any body lotion, and you will stretch. You will give the stretching for the cheeks muscles outwards, outside, right? Then with the thumb, you will push the child's chin upwards. This way, then clockwise and anti-clockwise. And you will press his gums from outside also. Here and here. Then blowing, sucking and massage inside the mouth. You can use battery toothbrush also. With the battery toothbrush, he will get vibratory massager to the oral muscles. And give the child a food, crunchy food items for chewing for the longer period. So chewing is also the exercise to improve the muscle tone. I hope the participant got the answer for his or her queries. Okay. One more question is there. Is there any age limit for occupational therapy treatment for the children with ID? No. There is no limited age for the any therapies, not for the physiotherapy, not for the occupational therapy, not for the speech therapy. You can start therapy at any age. Okay? You can start therapy at any age. But you ask for the child with ID. Yes? So for the child with ID, in occupational therapy point of view, you should use lot of teaching and learning material for improving their hand functions and their cognitive skills. Teaching and learning material. We suggest the parents don't give gadgets to their children, at least for the younger children. So you should use lot of teaching and learning material like ring tower activity, then pegboards, abacus, thread and beads activities. There are many material available in the market, geometrical shapes, alphabet shapes, number shapes. So the child should perform those activities by self with your instructions. So with this type of activities, you will improve his hand functions, his eye-hand coordination, sitting tolerance, and his cognitive skills. Hope you are satisfied with my answer. Okay. So no more queries? Speech therapist. She's speech therapist. What she's asking?
Thank you.
अच्छा ठीक है.
इतने डोसे लगे पेपर में देते ये ठीक है जीवन ये और ये
At the same time.
Yeah.
Windows.
Yeah, I pressed. Again, I will.
कैमरा पे देखिए ये हाँ
And it's only.
मोबाइल से
On the page of opportunity. Number one.
Right?
Exam child.
मीडिया वाले आए आपके वहां पे?
No, really.
You told her in Department of Therapeutics?
It was the exams.
अच्छा. You are always welcome, sir. Sir, आज मेरे को चाय पिलाएंगे.
Ah.
चाय और समोसा देंगे आप में.
And number 4 o'clock, yes, yes. Good afternoon, all the participants. Participants, all of you should be ready to take the examination. Once again, I am remaining. All the participants has to give the examination. And you should get a score of 70%. Then only your CRE points will be credited. ఆయన కాల్ చేస్తారేమో సార్ ఆయన కాల్ చేస్తారు. Stay on online for a few minutes.